All right. So as you all know, we are now being recorded. So I apologize about that, about missing the introductions in the recording, but the introductions are just BHA. So you guys deal with us all the time. All right. So with that said, we've got just a couple of announcements. Looks like one of our presenters, Blake, got kicked out. Gene, there is not a waiting room, so he can go ahead and just I disabled the waiting room so he can just pop back in. Cool. Okay. So with that, we just have a couple of announcements for folks before we get moving with our presenters. I just wanted everybody to know we need those vendor contact forms. You were emailed those by Kelly, I think a couple of weeks ago. And those are required for our new fiscal year contracts. We want to make sure everybody is correct on the contract. We want to make sure we have names, email addresses, everything's correct on our contract. So please get those vendor contact forms in to myself, Kelly, or Athena. If it goes to one of us, it'll work out. If it goes to all three of us, that'll also work out. So please get those forms in. As you know, we're preparing for fiscal year 26. So budget information will start coming out soon. If you have questions about your prospective budget, please talk with myself or Kelly, whoever manages your program. We don't have those budgets set quite yet, but they need to be in by the 28th of this month. So we will have them set by the 28th of this month. And we'll try to reach out to you to let you know what your budget's going to be. But Athena here is also super quick on contracts. So if she beats us to the punch and you get your contract and before we reached out and you have questions about your budget, please reach out to Kelly or myself. With that, Alex, did you have any announcements?
Nope, not today.
All right, awesome. How about you, Danielle?
Nope, I'm good. Thank you.
Cool. Athena, anything?
No, thanks for mentioning those contract sheets. I really need those so I can get the right signer on the contract.
Well, thanks, Athena. Yeah. Please get those in as soon as possible. If you don't get them in pretty quickly, you're probably going to get an email from me saying, let's get those in, and I'm going to give you a date. So if you don't want an email from me, please get those in. If you do want an email from me, then you'll get an email from me. With that said, I'm going to go ahead and pass things over to Gene and his team. And Gene, I'll go ahead and let you introduce folks and let you introduce your program if that works out. And I'll be here for any technical assistance or anything that y'all need.
Thank you. So my name is Gene Klavansky with the State Court Administrator's Office. 3 of my team members are here too, so I'll definitely have them introduce themselves as well. The main role today, we just wanted to introduce and put new legislation on your radar. You guys are probably aware of it, but competency diversion, or HB 24.13.2025. We work with competency court docket coordinators. So 2 separate programs. There could be a competency docket that runs traditional competency tracks with evaluations, restorations, and the new piece is competency diversion that we have a presentation on. We hope to keep this pretty informal. We'll have space for questions at the end. But again, our main goal is just to introduce the legislation, what landscape might look like in the next couple months, and answer any questions. So again, we work with coordinators, help train them. We would obviously love to have connections with your teams. It's very important that everyone works together to make this successful. So let me pass it off to Kim to do quick intros, then we'll start our presentation. But again, thanks for having us.
Hi, I'm an analyst on the competency programs team with the State Court Administrator's Office, and my role is specifically to focus on a statewide evaluation, and we'll have a slide going over that as part of the presentation.
Hey everyone, I'm Patricia Ortiz. I'm a competency diversion analyst with the State Court Administrator's Office. I'm assigned to the southern region of the state, but also am working with the first JD, which is Jeffco and Gilpin counties, and Denver, Blake and I are kind of tackling that together. Do you want to introduce yourself and then we can get started?
Patricia, it doesn't look like Blake has been able to rejoin us.
We're in offices next to each other.
Oh, there he is.
I'm working on that computer over there. So my apologies. I'm Blake Newbert. I'm the other competency diversion analyst doing the northern region, as Patricia said. So my apologies for missing that.
All right, so we're just gonna, I'm gonna kind of start with our presentation here. We are a 4-person team at SCAO, and like Jean mentioned, we are working on a few things. So we have House Bill 24-1355 that was passed in June of last year by the state legislature, which created our competency diversion programs. Some of you may have already been involved with, may be involved with a competency docket in your county jail. And so I'll kind of discuss the difference between the two. Kim will tell us about the statewide evaluation and what that brings. Blake's going to kind of talk about the Judicial Mental Health Advisory Committee. And then we'll discuss collaboration and then be open for any question and the answers. If you do have questions throughout the presentation, please feel free to raise your hand, and then we'll go from there. So I got to move my screen around. Sorry, guys. So to start, again, the competency diversion programs, it was a bill that was aimed to establish a structured referral process for defendants who are likely to have been found incompetent to proceed or have a history of incompetency to proceed like former court cases. It seeks to redirect the individuals from traditional competency proceedings and the broader criminal justice system, which will put them into the Bridges Wraparound Care Program. That program will focus on providing comprehensive support and services to address the individual's needs effectively and in the community. So basically what happens is a person who is likely to have been found incompetent to proceed or has a history of it. And even those who may be suffering from mental illness while, they're having touch points with either your teams or the mental health teams in the jails, they can be flagged for competency diversion. And anyone on the team in a lot of districts that are starting out can make a referral. So it can come from the JBBS team. It can come from the mental health team at the jails. It can come from the public defender's office, the district attorney. And then we also have our court coordinators who are involved in our dockets, who will have access to some of the jail records and who's been booked into the jail. Sorry, I have screens going crazy right now, guys. And so they will get referred into the competency diversion program if they meet the criteria. If the DA says, yes, we're going to let this person, or we're going to work with this person in the competency diversion program, that person will then be referred to the Bridges Wraparound Care Coordinator. The care coordinators will take a quick or do some assessments with the individual to decipher if they can actually work with these folks and provide the services that they need. Once Bridges Wraparound Care Coordinator says we can help this person, the court coordinators will get a notification, and they'll be set in front of a competency diversion judicial officer. And then that person will likely have a transition planned and bond set. And so, again, there will be court coordinators. They will track the participants through the process. And In order to be in compliance with the review process, the court has to hold a review within 182 days to assess compliance with the individualized care plan. Some non-compliance may lead to a few options. It can lead to termination of the program. It can also, the legislation allows for an additional 91 days to be added to the back end of the 182 days. So rather than 6 months, this person would go through an additional 90 days, which would be 9 months. Or the DA can elect to actually prosecute the case, and then that person would end up in the traditional competency route. So you're going to think of like competency evaluation, or competency will be raised. The court will likely order an evaluation, and then that person, if they're found incompetent to proceed through the evaluation process, will have to go through competency restoration. With 1355, we are actually required, the state court administrator's office is required and in charge of most of the data collection. And we will collaborate with Bridges of Colorado, but most of the data collection will be on us. And Kim can probably talk a little bit about that within the statewide evaluation. So like I said, I was going to talk about the difference between competency diversion and competency court dockets. So competency diversion is legislatively mandated, and so it has a distinct process. Again, they will not be evaluated and they will not be enrolled in restoration education. This is designed, the person will be likely to have been found incompetent to proceed or have the history of that. The district attorney is basically the leader and main decision maker of in these cases, and so they have the ultimate, what we're calling, veto power, and so they can waive any like, say there's a sex offense or crime of violence, they can waive that and still allow someone into the competency diversion program. And so a lot of the examples we use in instances like this are, you have someone who suffers from dementia and they sexually assaulted, a family member or someone they know, or someone they don't know. And because of their mental illness or the dementia and their IDD, they're never going to reach restoration. And so they would maybe be allowed to be in that diversion program. A competency court docket is a court-managed docket, and it's specifically focuses on judicial oversight for competency restoration cases. And so again, that's going to be your traditional competency is raised, evaluation happens. If they're ITP, they will go to restoration education until we get a finding of restorability or non-restorability, and then that's when things either go back into the prosecution line, or when non-restorability is found, then the case has to be dismissed per statute. So kind of the process for competency diversion. We are currently working with some of the districts who are having to roll out competency diversion on April 1st in working their getting the mandatory participation through the memorandum of understanding. And so the chief judge of each judicial district will enter into an MOU with the various stakeholders. And so that includes like your district attorney's offices, your public defender's office, Bridges of Colorado, the Department of Human Services, the Behavioral Health Administration, community-based treatment providers, and local behavioral health case management programs. The operational vision is that the MOU must outline an operational vision for the referral process tailored to each judicial district. The Office of the State Court Administrator we've coordinated the creation and revisions of the MOU. The parties who enter into the MOU, they have to collaborate with community groups advocating for individuals with mental health disorders. And the process and frequency of the revisions to MOU will inform the initial MOU. Each district has the ability to create their own referral process. A lot of again, it's DA led, and so they have kind of that power. Again, if the defendant is charged with a class 1, 2, or 3 felony, a class 1 or 2 drug felony, a crime of violence, or a sex offense, the defendant is presumptively ineligible for competency diversion unless the DA waives that ineligibility. And usually that'll be in the interest of justice. So to kind of talk about the timeline and the rollout, the first implementation has to occur within or by April 1st of 2025, and then the rollout continues through July 1st of 2026. And I'll go into a little more detail in the next slide. We also have, so the Bridges Wraparound Care Program participation requires that the participants enter into a written agreement that is developed, we've developed an individualized wraparound care plan for that person. And so we're taking into consideration mental health and or care for mental disability, substance use, housing, transportation, basic needs, health insurance coverage, employment, and employment, we say if that's applicable to the individual, and then other social determinants of health. As far as the court involvement goes, we are basically only involved at the front and the back end unless someone is being non-compliant. And so the court is required to release a defendant on a PR bond if they're in custody and accepted into the program. Non-compliance can lead to the revocation of the bond, termination from the program, and then prosecution of the original offense. With information sharing, the DA is required to have access to reports and information related to an individual's compliance with their care plan. And then by consenting to participate in the program, the defendant waives any claims to confidentiality regarding those reports. We will have Bridges writing reports and presenting them to the court. Basically every 30 days, they'll submit a report so long as the person is being compliant. And then we may see, if someone isn't being compliant, we may see reports a little soon, probably, well, after the 30 days sooner, before the 60-day mark. Sorry. All right. And so this is the implementation timeline. We have the second JD, the 17th, 18th, and 20th. So that's basically Denver Juvenile. The 17th is Arapahoe and Broomfield counties. The 18th is, Adams and Broomfield counties. The 18th is Arapahoe County, and the 20th is Boulder. They are all required to roll out their competency diversion program now in April 1st of this year. All of their coordinators have been hired, and we are asking that you all be open to collaborating with the coordinators as they're hired on. I think they're going to be reaching out to all of you because we're referring them to you to build that collaborative effort and bring you all to the table. The second rollout happens in October 1st of this year. And so the judicial districts included in that are the 1st, 4th, 5th, 6th, 8th, 15th, 16th, 21st, and 22nd districts. And so of those, we have 3 of the coordinators hired, 1, and then there are 2 in the hiring process right now. Actually, there are 3 in the hiring process right now, and then 2 of them haven't posted yet. And so we're working with their court executives and chief judges to kind of see what their plans are and how they plan to move forward. And then in July 1st of 2026, the the remaining districts, which include the 3rd, 7th, 9th, 10th, 11th, 12th, 13th, 14th, 19th, and 23rd, are all required to roll out competency diversion by those dates. And so I'm going to pass it on to Kim now.
Okay, and I'm just going to briefly talk about our statewide evaluation that we have going on in our criminal justice programs unit. My position was actually made possible by a federal grant. It's a 3-year grant that started back in October. And basically what we're trying to do is, if you're familiar with problem-solving courts, we're trying to get a system in place to develop key components. We've actually changed this to developing key principles for competency court dockets. We're going to be looking at establishing best practices for competency court dockets. We are also going to be looking at evaluating outcomes. We are going to be working with National Center for State Courts, who has been selected, and they'll be coming on board officially in October to help us evaluate what we think are best practices for these courts, what we think are key principles for these dockets. And then part of that process is going to be including some pilot sites statewide. So hopefully, a couple of metro districts, hopefully a rural district, so we can, once we identify what we think these things are, that we can implement those. And then we're going to be using our data information system, or the DIM system, to track that information to see if those are things that are actually effective and efficient for this population in the competency court dockets. There is a DEI component. We want to make sure that all participants that should be able to benefit from being in a competency court docket are having access to being part of those dockets. And then the final step of that would be taking all of that information, disseminating it statewide, and then implementing training for best practices, key principles, and other things, I'm sure, just like problem-solving courts that we're already doing, motivational interviewing, trauma-informed communication with participants, educating our bench on how to best interact with this population. And I think that covers everything. Thank you.
Blake, you're on mute.
Oh, I said some really cool stuff too. You guys just missed it.
And we missed it.
Really inspiring. Dang it. Just wish I could remember. So yeah, this slide is you'll hear us call it JMAC, but it's the Judicial Mental Health Advisory Committee. And right around last May, at the time, Chief Justice Boatwright issued a Supreme Court charge saying that there needed to be a group that kind of is the governing or the main board or group of people that are going to kind of make the decisions and hear the issues throughout the state of competency and other mental health stuff. It's, I believe, around 16 members, most of them judges around the state. There's 3 different subcommittees for evaluations, education, and training, and partners. They're all actively meeting at different intervals, but kind of still getting established where they're at. So all pretty new, but we're very excited of what's happening. And I'm going to appear to be a very lazy person and just read this, but this is the official line for it. So JMAC is a platform for collective problem solving, unified communication, and strategic alignment among judicial officers regarding mental health within the court system. Through collaborative efforts, the JMAC can shape a more informed, effective, and compassionate judicial response to the complex challenges presented by the mental health issues in Colorado's courts. And so the next piece, we already talked about it, the collaboration part. The first two, hopefully your Bridges folks and your forensic navigators. Here's a link that'll get you who your contacts are. I know that probably needs to be updated quarterly. I'm thinking it's probably pretty current. I know there's some change-ups happening in both of those right now, but this at least gets you involved in like the regional managers and the forensic navigators. So those would be probably not super different than what you're used to. Number three would be more of where we're coming from. These are the coordinators that are active right now. And you can see that list. I'm not sure if people have reached out to you at all, but these are the folks that'll be the coordinators in the comp dockets and within the 1355 wraparound diversion. And it's going to be really valuable for them to be able to work with you guys because you're going to really know so much about your population and your clientele, especially with some of that diversion stuff. When someone's coming back through the jail, you're going to hopefully know, hey, they're back from the last time they were here. We're going to let you know that they're involved again, so you can hopefully maybe get them back in the diversion program. So a really good relationship is going to be super helpful for everybody to work with that. We're going to try to make sure that they're super involved with you and the jails as well. So this is the list of folks. We're happy to send them out. We'll keep the updates going of who's been hired. The 8th, they should have theirs in the next couple weeks. They're interviewing right now, but this is a list right now of everybody that's actively hired.
I also think we left out the 5th judicial district on this list. The 5th is also in the hiring process. So we have the 5th, the 8th, and the 16th currently in the hiring process. We also have a list of the coordinators by their respective districts that we're happy with their email contact information. Happy to share that with you all via email if that's something you'd like. And then after we get out of the slides, I can share those 2 links for the Bridges regional managers and then for the FST folks as well. So that's kind of what we have prepared for you. We're happy to answer any questions that y'all may have.
Any questions from anybody? Please feel free to take yourselves off mute or type in the chat. Nothing. You guys shared everything. But Patricia, would you be able to put that information in the chat, or does that have to be shared via email?
As far as the contact information goes, I'll have to do that via email. It's like an Excel spreadsheet. And so I think that'll be easier and cleaner via email than here in the chat.
Okay, no worries. Yeah, so if you guys are wondering about that, if you could reach out to the team, could the team put your email addresses directly in the chat? The invite is gigantic, and I don't want anybody to have to sift through the invite of 200 something, 300 something people. You could put your email addresses in the chat, and folks could reach out directly. Cool. And that can be done during our next presentation too, or whichever. Awesome. Thanks, Jean. Thanks, Kim.
Also, if I could add, I mean, it's been hit, but we obviously think that this team should be part of a lot of these conversations, part of the MOU. So folks might be reaching out to you guys if you want to have a conversation with our team, in a smaller forum. We can definitely do that. But just keep an eye out for a coordinator reaching out just to have a conversation. But jails, contract, they're very valuable to getting people the help they need quickly. Early identification is part of this diversion plan. So if you know someone has a long competency history, you can reach out to the coordinator. The process can start sooner. So again, early detection, identification is part of it. If there is a point person on your side that you're comfortable with us sharing with the coordinators, please let us know as well. If it's you, Becky, great. If it's someone else, we can definitely do that. But we meet with the coordinators on a weekly basis. We can pass whatever information you think is valuable. So please, two-way communication. Let us know what you think coordinators need to know, and we'll do the same as well. But again, if there's a point person, we'd love to connect the coordinators with you guys.
Yeah, you can pass on my information, Gene. That'd be fine, and then I can help connect folks directly. That'd be fine.
Great. And we put other information in chat as well. There's a link to the statute. There's the timeline in there. Again, if anybody wants to have a conversation with us, please reach out. We'd be happy to talk to you.
Additionally, I'd like to add, we've been working with certain county jails who have created like it's a bi-monthly collaboration meeting, and it's basically they kind of gather resources and whether they're like sober living facilities or their community mental health partners. Our team has attended some of these meetings. It's been a really big help for court coordinators who are involved in the competency dockets and competency diversion programs to really kind of get to know people. It also has created some really great staffing of case options. Like, I really need this for an individual and I can't find this service. And like, I've been in a collaboration meeting where, we have 50 people in the room staffing a case. You're not sharing any identifying information or anything, but we've really found this to be a really helpful tool and success. And so I'm just throwing the idea out there for all of you folks who are involved with the JBBS teams. It was created by a programs manager and JBBS team in the metro area. And so I'm just throwing out ideas and throwing the plug in, so maybe you can come up with something unique and helpful for your communities.
Cool. Awesome. Thank you. Any questions? Anything for the team? Looks like you guys have a couple of contacts in there as well. Jill Gates is with Pueblo. Lieutenant Sims is with Summit County.
Thanks for sharing that. And thanks for giving us a platform, and please reach out if we can help in any way. We appreciate it.
Absolutely. You guys too. And we can help connect to folks as well. So thank you. Thank you for being here. For everybody on the call, if you've got questions, please reach out. And for everybody on the call, we're going to go ahead and move on to our next presenter. Sandra, are you here?
I am here, Becky. Can you hear
Awesome. So we have Sandra Bianchi Martinez. As you can tell, there looks like there's Brixati in the background there. Oh no, Brave. All right, Brave. I'm sorry. I was ahead.
So close. So close.
Sandra is going to go ahead and present about Brixati. She put one link to Brixati in the chat earlier. It was at 2:28. So if you guys scroll up, that is there. But Sandra, I'll go ahead and leave it to you.
Great. Thanks, Becky, for inviting me today. And thanks everyone for sitting through some information on Brixati. I'm going to share my screen, not the best with Zoom. So we're hoping this works out. Okay, let's see, share. Can you all see that?
Yes.
Perfect. All right. So yes, my name is Sandra Bianchi Martinez. I work for Brayburn, which is the manufacturer of Brixati. We've been approved since May of 2023. So it's buprenorphine, injectable buprenorphine. So buprenorphine, not new, just a little bit of different technologies. So just for the sake of time, I'm going to walk through a lot of this quickly. If there's any questions, please put it in the chat or your information and we can connect afterwards. But I'd like to start here just because when you think of your population in the jail, many of our folks with opiate use disorder are on oral medications. While that's wonderful during the jail time with you, when they release out of jail, oftentimes individuals do not stay on their prescribed medications or pick them up or whatever the situation. So we actually looked at a claims database that's over just under 250,000 people, and it shared that about 30 to 60% of the population that is prescribed like oral buprenorphine discontinues within 30 days. So that tends to be a challenge for someone with substance use disorder or any mental health, making those good decisions every day can be very challenging. About 93% of the population is actually on oral medications, and oftentimes they're discontinued rather quickly. So let's see, how do I move this? Okay, I can't click. So before we kind of dive into Brixadi, I just want to make everybody aware that injectable buprenorphine is always a part of a REMS program with the FDA. This is not a medication that is a take-home medication for patients. It's not a medication where a patient goes to a pharmacy and picks this up. It should be only administered by a healthcare provider. And the reason for that is if someone were to inject intravenously, they're at risk for serious harm or potentially death. So always and only, administered by a healthcare provider. Brixadi. So Brixadi, it's buprenorphine. This is not a new medication, but what Braeburn did is we used a different technology, and the technology is called a fluid crystalline technology. And because of the technology that's different, it lends to different features that you may not be familiar with another injectable product. So we are the only injectable product that you can have in a weekly formulation or a monthly formulation. So in terms of injectable products, they definitely are not the cost of what an oral medication, but our weekly medication is generally a fourth of the cost of what our monthly population. So for the jail-based setting, that may be an important factor in looking at injectable products. So we have the weekly, we have the monthly. We also have a very small needle. Our needle is 23 gauge, and it's about a 1/2 inch long. So it's a small needle in a very small volume. The largest volume of any of our doses is 0.64 mL, and our largest monthly dose is 0.36 mL. So it's a very small amount when you inject it. Very rarely would it be palpable where you could see it, feel it. It's literally about the size of a pea. And then lastly, the other piece of our technology that lends to no refrigeration. So this product should never go in the refrigerator. So that is the technology. Looking at plasma level concentrations, right? So the gray lines that you're looking at in the top and bottom graph are oral medications. And you'll notice that every single day you take an oral medication, it peaks and it troughs. So most of the folks waking up in the morning are in their trough. That's when they don't feel good. They're starting their day off not feeling well. You'll notice that our medication has a nice even distribution of the medication through the dosing window. The top graph is the weekly, the bottom is the monthly. Steady state for medication for our Brixadi is just the number 4. So 4 doses for weekly or 4 doses for monthly. Okay. And I just want to point out at the bottom of these slides is all our important safety information. It's a lot of information. I did put the link in our chat to our actual website that has our full prescribing information and med guide. So, if you have some time and want to read through our med guide, it's all there for you in the chat. We did 2 trials. The first trial we did was a phase 2 trial with the FDA. The purpose of doing a phase 2 trial is, does buprenorphine work in our technology? Is it effective? And so we looked at a group of individuals that were moderate to severe opiate use disorder that were not seeking treatment. And we wanted to look at their drug-liking effects, right? So in the very beginning, we gave them 18 milligrams of hydromorphone, IV, intravenously. And you can see their drug liking in that first column in the blue, that their drug liking for hydromorphone shot up pretty high, which we would expect. But we then put them on 2 doses of our weekly 24 and 32 milligrams of Brixadi. And then we tested with that 18 milligrams of hydromorphone at the beginning of the week, end of the week. And during the entire dosing interval, their drug liking stayed below complete blockade. So this did show the FDA that using buprenorphine in our fluid crystalline technology was effective. And if there are questions, I just ask to hold them to the end or put them in the chat, and we'll make sure we follow up on those questions. So the third trial that we did, this is our pivotal trial with the FDA for approval of Brixadi. And this trial was done differently than any other injectable product. Instead of comparing Brixadi to placebo, we actually compared it to the standard of care, which is your sublingual buprenorphine, Suboxone. And the whole intent of this trial was not to show, we just wanted to show, did we work equally as well as the standard of care in treating an opiate use disorder, which is Suboxone. So there's a lot of information here, but just to break it down, we had a few different phases. First phase was weekly, second phase was monthly. It was 6 months in duration. If they received Brixadi, then they received the placebo and vice versa. I do like to point out in our clinical trial, we did have about 25% that were positive for fentanyl. So we did have the fentanyl folks in our group, but as you would expect, a lot of polysubstance at this time using heroin and injecting. I think we've seen a trend more go to smoking, but that's how our clinical trial was designed. And we were looking at responder rates, right? So we were looking, do we respond as well as someone on, the sublingual buprenorphine? And so it was a rigorous trial during different time points. During phase 1, phase 2, they had to have negative opiate screens. If they did not show up for an appointment, they were considered positive. And through the entire 6 months of the trial, we actually showed we were non-inferior, 16.9 versus 14%. So then we looked at a secondary endpoint, and I think, this kind of speaks to me just in general, is that we looked at negative opiate screens. So the folks that were on the Brixadi arm of this clinical trial, we showed that we were statistically superior to folks that were on daily sublingual buprenorphine for negative opiate screens. There was a 31% mean difference with negative opiate screens when you're on the injectable Brixadi versus when you're on the daily sublingual. So we did show a decline in opiate cravings and withdrawals, but we did not power to look at that between the orals and Brixadi. So just in terms of you're thinking of when folks release out of your facilities and they're taking the daily oral or they discontinue, we did show the difference in the negative opiate screens. And then because we did our head-to-head trial directly against Suboxone, we were able to line up the adverse events. So generally providers, when they're treating their patients, they're looking for products that, one, are efficacious and two, that are safe. So what we showed here is there wasn't anything that stood out in terms of adverse events. The things that you would expect with oral, you would expect also with Brixadi. So, the headache, the constipation, the nausea, those are all side effects that are reported with buprenorphine. So the difference is this is an injection, right? So I've worked with a lot of different injectable products, and oftentimes injection site reaction is in the warnings and precautions of a label. But with Brixadi, it was not. What we saw in our clinical trials, that all the injection site pain and all of that was in mild to moderate. We didn't see any in severity of intensity. So, you're looking at a product, an injectable product, which is hard for some people to raise their hand and say, yes, I want an injectable product. But because it's not refrigerated and has a very small volume and very small needle, I think is attributing to, not having the severity of injection site reaction. Dosing. So if someone comes into the jail and you can verify and that they're on buprenorphine, you can go directly over to the weekly or monthly formulations. The gray column is the oral conversion. So if they came in on, say, 20 milligrams of daily oral Suboxone or sublingual, you can go directly over to the 32 or 132 milligrams weekly or 128 monthly. Many times we don't know what individuals are coming into us, what they've taken, what they're on. It's hard to verify that. If you do not know that they're on buprenorphine treatment, you would give them a 4 milligram test dose of oral. And you want to do that because if someone comes in on a full agonist, fentanyl, I don't know, methadone, they've got methadone on the street. Buprenorphine has a very high affinity for that receptor, and it will knock that off. And if it knocks it off, they're going to go through precipitated withdrawal. So that really tells you kind of, do they have opiates in their system, a full agonist? We don't want to give them an injectable product if they have a full agonist on that receptor. So that just gives you bring them into, mild to moderate withdrawal, 4 milligrams. If they don't precipitate in 1 hour, you can go ahead and give them the 16 milligrams of weekly Brixadi. So you literally can initiate Brixadi within 1 hour, which is nice in the jail population because sometimes we don't have them there that long, and having Brixadi on board as they go out just provides them that medication that we know is in their body, and they don't have an option to take it out or not take it. So again, just kind of the different features of Brixadi. For the jail-based population, not having to refrigerate it is really nice. It is a controlled 3, so you absolutely do still have to lock Brixadi up. I didn't talk about this, but we do have multiple injection sites. So often injectables you can only give in the abdomen or the glute. With Brixadi, you can give in the abdomen, back of the arm, the glute, or the thigh. So you have a lot of different options of where to inject it. We do recommend that you rotate the weekly dose. And when I say weekly, it doesn't mean going from abdomen to glute. It just means not in that quadrant. And again, very small needle, very small, small needle and small volume. And so when you think about, individuals getting an injection, they're like, I don't want that. Just knowing that they don't have that severity of pain, they may be more open. And the experience for the nurses providing Brixadi and the experience for the patient really has a big factor if they continue on to treatment. The other thing I wanted to bring up is if they're on monthly, you can give monthly 7 days before or 7 days after. So you have a really wide window, especially when you don't know when someone's walking out the door, or their time got moved up and they're getting released earlier. So you have some of that flexibility with the monthly. On the weekly, it's 2 days before and 2 days after. So those are just some of the different features that our technology lends to. It's just one of those things of having all treatment options on the table for individuals to know that there are options. Sometimes individuals don't know that an injection is an option, and we think they're doing well on their medication. But if we really start talking with them that, hey, here's another treatment option for you. I think just having some of those individual treatment decisions. And with Brixadi, because we have so many different doses of the weekly and the monthly, that you can really individualize care for the patient. Not everybody needs the same amount of buprenorphine. And so if you start them on, say 128 milligrams of the monthly, and you see side effects like they're tired during group, they're nodding off, you have the ability to back down that medication, right? And vice versa. If you give them, 96 milligrams of the monthly Brixadi, and if they're still feeling symptoms, you have that option to go up. So you really do have some good ability to individualize treatment. So that is it, Becky. I went through that really fast. And if there are questions more on like the details on the clinical trials, I'd be happy to share that. I'm going to stop sharing.
Well, Sandra, it looked like there was one question in the chat. Well, it looks like 2 now. Is this something that Medicaid would cover? Do you know if Medicaid covers it in Colorado?
Question. Thank you. Great question. Yes, it's fully covered in Colorado by Medicaid. Denver Health Medicaid, I believe they can get it. They just have to jump through some other, hoops, but your fee-for-service Medicaid, they can get it, no prior auth, it's fine. So, yeah.
Well, thank you. And Sarah is asking about general costs. Do you know about the cost?
Yes, I do. So, everybody acquires medication in different ways, right? So when you're working with injectable buprenorphine, there are specialty distributors, specialty wholesalers. So depending on how you get it, but just as a starting place before any sort of discounting, right? There's an average wholesale cost. So the average wholesale cost for the weekly is $427. The average wholesale cost for the monthly is $1,708. So the weekly is 1/4 of the cost of the monthly. So we wanted to make sure we worked with CMS to make sure that we priced it like that, because we don't want medications to be chosen because of cost. We want it to be chosen their specific dose because that's the right dose for the patient. Colorado has a really nice community that is providing Brixadi in the community. So, I mean, unless you're in a very tiny rural setting, that may be where we work together, right? So if you have community partners that you work with in the community and you want to do an injectable MOUD program, let's work together with your community provider. We have a team that works with the community that will go out and educate them. But generally right now, up and down the I-25 corridor, there's very good access to Brixadi, even in some of the rural areas. We're working on a provider locator, but we're just building it out right now. So what I would say is if you want to look at injectable products in your jail with your community, let's just work together. Just call me. Yeah.
Sarah's also wondering, do you have a wholesale contact to reach out for a pricing discount, like a phone number?
You know what? Hey, let's see. Whoever needs that information. So on our website, okay, I'm just going to go over to my website. Hold on, I'll show you. Hopefully it's there. I'm going to share my screen. Can you see my screen or no?
No.
Okay, hold on. That didn't work. How am I going to do this? Share screen. You guys might see a lot of different things. Here. There. Can you see that? This is the website is brixadihcp.com. That is our website that has all of our clinical information. There's something here. There's a tab called resources. Okay. And we're going to scroll down. Let's see. Full dose. So just for everybody's information, there's our full prescribing information you can download. The dosing guide chart, you can download that. If you want to do Brixadi, I would highly suggest working with myself. We really want to work with the medical teams on how to inject Brixadi. It's different than some of the other sub-Q injections. So there definitely is some tips and tricks there. Let me see. I'm just going to scroll down. Sorry if I'm making you all dizzy. There is a specialty distributor contact information. So for most jails, or correctional facilities, I'm just going to open this up. Hopefully it's updated. This is the list of different wholesalers that you can acquire for corrections. So Bessie Medical is one. We have a contract with Cardinal through MMCAP and Cardinal, which the state is a part of that. We have a contract list with CuraScripts, with Henry Schein, and there's one more we just added, which was Boswell. So the reason why correctional facilities like to bring it in wholesale, if you bring it in by specialty pharmacy, it comes in patient name. So I'm just going to stop sharing. So that's where you can find it on the resource page. If you bring in Brixadi via specialty pharmacy, we also have Diamond Pharmacy. So if your medical teams acquire medication through Diamond Pharmacy, that's a specialty pharmacy for corrections. They also have Remedy Repack for distribution, which is like bulk ordering. The difference between the two is specialty pharmacy, it comes in patient name. So with the DEA, if it comes in patient name, if you don't get it into the patient within 45 days, that medication technically needs to be destroyed. If you bring it in by wholesaler, those correctional wholesalers, it does not come in patient name. So if you plan to give Brixadi to, say, Mr. Smith, and Mr. Smith releases before you get the medication in, the next person that wants Brixadi, you can use that Brixadi for, because it's not in patient name. So you're not at risk at losing that injectable product. And I'm happy to talk with anybody to really kind of understand the whole acquisition piece of an injectable product, because it is different, and there's very specific people that you can get Brixadi through. So the list I showed you, Cardinal, Bessie, CuraScripts, Henry Schein, there's also Diamond, Remedy Repack, and there's also Boswell. So those are the correctional pharmacies that you can acquire Brixadi through. And that price between your specialty distributor and you, that is the decision of that specialty distributor. So we give it at their wholesale costs that I shared with you, and they do some discounting there. But what they sell it to you as, that we don't have anything to do with that. That's between specialty distributor and that particular facility. Some choose to give it at a wholesale acquisition cost. Some choose to mark it up 3%. Some choose to discount it. So it's a very complex answer.
No, that works perfectly. Thanks, Sandra. I think we got our questions in the chat, and we're about out of time. We're at 3:01 now, so we're a little teeny bit over. But does anybody have any other questions or concerns or anything? Sandra, could you put your contact information in the chat as well, and folks can reach out to you?
Okay, let's see. I have a very long name. Wait, I'll put my
I don't know.
email.
I think I'd probably beat you. I think I beat you.
Really?
Yeah.
Oh my God.
Becky Huckabee is short for Rebecca Huckabee Rafelson. So I think I win.
You win. That's
right,
my
cool.
email.
Thank you.
Yeah.
Thank you. So everyone,
Thanks so
please
much.
reach out if you need anything. And thank you, Sandra, for being here.
Yes.
And everybody, thank you for being here today. Please let us know if you need anything. So it's great stuff today. And I will be stopping the recording here in a second.